I guess, Aline, can we go live, right?
Yep, we're good. We're ready to go.
Okay. Hi, welcome everybody. We have a great talks for this QI, basically talking about optimization and the real world data analysis. Just an introduction myself, I'm Prashanth Sreeramoju. I'm a general surgery MIS surgeon at Montefiore Medical Center in New York. And I'm great to be a part of ACHQC. I think it really helps. So to begin with, let me introduce our first speaker, Ivy Haskins. She's going to talk about, does hernia central label provide better 30-day outcomes and analysis of ACHQC database. She's from Nebraska, and she's with strong work on hernias. So go ahead, Ivy.
Okay. Can you guys all see this?
Yes.
Okay, and you guys can hear me?
Yes.
Okay. Good evening. I'd like to thank the QC for the invitation to present. Tonight, I'll be discussing if hernia center label provides better outcomes. I'd like to thank Lee Ching for her statistical support for this project. And as always, it's a pleasure to work with Dr. Perez. Many medical and surgical subspecialties have developed centers of excellence with the proposed benefits of improved quality of care with an associated decreased cost of care, resulting in an overall increased value of care provided. Unfortunately, however, the proposed potential of centers of excellence have not always translated to realized benefits. For example, the direct effect of CMS limiting coverage for bariatric surgery to centers of excellence was to limit access without improving overall quality of bariatric care. Currently, more than 1 million ventral and groin hernia repairs are performed annually in the United States. It is well known that there is significant variation in surgical technique amongst both hospitals and surgeons that manage hernias. Recent data suggests that both the incidence and cost of ventral hernias are increasing, with an estimated $32 million saved per 1% reduction in ventral hernia recurrence. As a result of the increased incidence and costs associated with ventral hernias, the idea of hernia centers has been introduced as a way to improve the quality of hernia care provided, while also decreasing healthcare costs associated with hernia surgery. Nevertheless, there is no agreed upon definition of a hernia center, and no study has investigated the association of hernia center designation with ventral hernia repair outcomes, which leads us to the purpose of our study, which is to investigate the current utilization of proposed hernia center components and to investigate the association of hernia center designation with 30-day, 1 year, and patient-reported outcomes following ventral hernia repair. In order to do this, we use the ACHQC database from the years 2012 through 2020. Patients were divided into two groups, including those patients that underwent ventral hernia repair at a designated hernia center site, and those patients that underwent ventral hernia repair at a non-designated hernia center site. An institution was designated as a hernia center either through self-identification from the survey that we sent to all members of the QC in the fall of 2020, which I will discuss momentarily, or through an online search that revealed hernia or abdominal core health center, institute, or program associated with the name of the institution. The primary outcome of interest included the difference in the incidence of 30-day wound events, while the secondary outcomes of interest included any difference in the total number of 30-day complications, as well as the 1-year ventral hernia recurrence rate and changes in patient-reported outcomes. A 1-to-1 matched analysis was performed between patients who underwent ventral hernia repair at a designated hernia center site and patients who underwent ventral hernia repair at a non-designated hernia center site. Patients were matched using variables to control for complexity of the ventral hernia repair, in addition to the variables known to be associated with 30-day wound events and 1-year hernia recurrence. First, I'd like to discuss the results from the survey that we sent. For those of you that were at a participating site as of the fall of 2020, you should have received a link to complete our survey, which is displayed here. I'd like to highlight the last question of the survey, which really gets into the potential components of a hernia center. The components of this question were based on the article by Cockerling that proposed a definition of a hernia center as well as a tiered system of hernia centers based on the number and type of hernias repaired annually, multidisciplinary surgeon involvement, the percentage of short and long-term patient follow-up, the percentage of morbidity events, involvement in national hernia societies, and academic contributions to the field of hernia surgery. Data from a total of 261 sites are included in our results. There were a total of 41 total sites that responded to our survey, of which 23 stated that they were a hernia center. Interestingly, there was significant variation in the participation of self-identified hernia sites with respect to the proposed components of a hernia center. Hernia centers were least likely to have a minimum hernia case number requirement and were most likely to submit data to a national database. Now for the results from our analysis. As previously mentioned, a total of 261 sites were included in our analysis. 78 were identified as hernia centers, while 183 were identified as non-hernia centers. While there were less hernia centers than non-hernia centers, a greater proportion of cases were performed at hernia center sites than non-hernia center sites. Prior to matching, ventral hernias repaired at hernia center sites had a larger median width, were more likely to be repaired with drains, were more likely to be repaired open, and less likely to be repaired robotically, had a longer operative time, a higher average ASA class, were more likely to be recurrent hernias, and were more likely to be repaired in the later years of the study time period. After matching, no statistically significant differences remained between the two groups. In terms of the primary outcomes of interest, there was a trend towards significance in terms of the number of 30-day SSOs in favor of non-hernia center sites. In terms of the secondary outcomes of interest, patients who underwent ventral hernia repair at non-hernia center sites were less likely to experience any 30-day complication or one-year ventral hernia recurrence, while patients who underwent ventral hernia repair at a hernia center had a statistically significant greater improvement in their Hercules scores at 1 year postoperatively. In conclusion, ventral hernias repaired at hernia center sites were more complex. After matching, non-hernia centers had better outcomes with respect to 30-day SSO, any 30-day complication, and 1 year hernia recurrence rates. After matching, hernia centers had a statistically significant greater improvement in Hercules scores at 1 year postoperatively. The label of hernia center is not standardized and does not provide information on surgical expertise, programming support, or dedication to quality improvement. The ACHQC database may self-select for surgeons invested in hernia repair outcomes, regardless of hernia center designation. Finally, a more standardized definition of hernia center is required in order to positively influence the value of hernia care. That's it.
Then you're muted.
Cool, there we go. Go ahead and share here, guys.
You guys want to do some Q&A first, or?
Yeah, that's what we were thinking. Ivy, that was a great presentation. Prashanth, do you have a quick question up front, or I don't want to jump in front of you. I know you introduced her in her presentation, so.
I don't have any questions on the QIA, but I do have one question. Like, what do you think about why the hernia centers have better outcome? Is it because of more resources, or is it because we are biased because we are interested in hernias itself?
Good question. The data actually didn't show that hernia centers had better outcomes, but they did repair more complex hernias. So the conclusion that we've drawn is that there's not a standardized definition yet of hernia centers. There's too much variability, which I think is why we're not seeing that there is an improvement in outcomes at designated hernia centers.
Ivy, I just have a tangential kind of question about hernia centers. I mean, we know that they're kind of a heterogeneous group, as you just mentioned through the research and surveys that you did. What do you think patient perceptions are about hernia centers when they're advertised as such? Do you have any information from a patient perspective?
I don't, but Dr. Prez and I thought it was really interesting that the one kind of difference or, improved outcome we saw for patients at hernia centers was their abdominal core quality of life was significantly better. So I think that there's a perception, at least, that they're getting better care at hernia centers. That's kind of the only conclusion that we could draw on, although we have not specifically asked patients.
Well, and the two outcomes that you mentioned, I think, were hernia recurrence and surgical site occurrence. Is that correct? That there was a difference or a trend towards a difference?
Yeah,
And,
there was, go ahead.
Well, I was just going to say that I think it's an indication that, or it's an example that those are some of the outcomes that we've traditionally measured and thought of as being the most important outcomes, recurrence, perioperative events, and that kind of thing. While they are important, there are lots of other measures of outcome. And I think maybe those will be touched on a little bit more tonight, but it's important to keep a little bit broader scope in terms of what outcome really means and what that means to patients too. They may not be as focused on some of the outcomes that we're focused on as surgeons. All right. Are there any other questions? Any questions in the Q&A? I don't see anything up there, but I don't want to claim that I know for sure how to use the Q&A tab. Does anyone else on the panel here see any questions, or are there any other questions or comments on Ivy's presentation? All right. Should we move on to Ben?
Great, Rob, Prashanth, thanks for having me. And really great to present at the Core Insights tonight. This is basically, it's going to be a story of the development of the hernia recurrence inventory. Pretty much all of us administer this to our patients in the QC as part of our PROs. These are my disclosures. So the bottom line is, no matter how we measure what our outcomes are in terms of quality of life, pain, other measures, recurrence is still a really, really important concept to measure. It's interesting, if you look at the article that we pretty much all quote all the time in terms of why we do what we do, especially with mesh use. This is Lewandike's article in New England Journal of Medicine in the year 2000. You kind of take a little different view of this, and it's kind of interesting. And this is one of the things that actually led myself to really kind of explore how to measure recurrence over time. So this is, in summary, their study. So they had 181 patients that they randomized to either mesh or no mesh. You see the number of patients that were randomized there. They measured recurrence after 3 years and found that in the mesh group, the incisional hernia repair recurred 23% of the time cumulatively. In the no mesh group, it was almost double that. It was actually double that, 46% of the time. But it's interesting, if you take a look and see how they actually assessed recurrence, this is straight from the article itself. They not only measured clinical recurrence, they also examined the patient's awareness of any recurrence of a hernia and concern about the scar. And they recorded that as a yes or no. I actually went back and asked Hans Jekyll, Professor Jekyll, how they did this. And they basically asked patients whether they felt a bulge back or if they felt that the hernia had come back itself, and just answered that as yes or no. They also used ultrasound to really kind of give the, as best of an objective measure of recurrence. So notably no CTs were used in this. And if you look at the article very carefully, it actually has a paragraph dedicated to the awareness of a recurrence on part of the patient. Basically, patient-reported outcomes in terms of whether or not they thought that the hernia had recurred or not. And this is something that's not very well popularized with this article. No one really talks about it. But if you look at this aspect of recurrence, at least in their study in a Dutch population, it was pretty close to their clinical recurrence. And there you can see, instead of 23%, 17%, instead of 46%, 35%. So not too far off. This is actually what led us to try and determine, can we figure out a way to actually measure recurrence just based on patient-reported outcomes? And going back a little bit, this is Mike and myself several years ago, both of us much younger. I had hair and didn't have any gray hair back then. When I started at Vanderbilt, and then Mike was at Case and then moved to Cleveland Clinic. Before the QC started, this is kind of an interesting historical note, there were a couple of tasks we had to do before really the QC launched. The first was really figure out how to determine recurrence, because we quickly realized that trying to have everyone determine clinical recurrence just wasn't going to be feasible. So So I worked on that at Vanderbilt, and Mike focused on infection and abdominal wall function. And of course, Hercules came out of that work. So all that prep work was done before we really started the QC. So just to go back and kind of show you what we did at Vanderbilt, we actually formed what's called the Vanderbilt Hernia Recurrence Cohort. These were 400 patients we followed prospectively who had an incisional hernia repair at least 1 year prior to their assessment. And we developed a technique called dynamic abdominal sonography for hernia. Basically, it's an ultrasound-based technique, and this is published in JACS. I won't get into details, but basically, what we showed that this is about as good as a CT scan, maybe even a little bit more accurate when done by surgeons who are familiar with this technique. It breaks down in folks who are a little bit bigger and have had multiple repairs, but overall, it's pretty good. The spectrum of options after those studies that we initially did, again, I won't summarize those, but basically it came down to this in terms of assessing recurrence either via physical exam, CT, or this dynamic abdominal sonography for hernia. On a spectrum of easy to hard, physical exam certainly the easiest. The ultrasound was the hardest to learn. The accuracy was probably closest between CT scan and ultrasound. Physical examination, we found actually was not that accurate, especially with the BMI over about 32. And then from a cost standpoint, certainly CT is the most expensive, with physical exam being the least expensive, and then ultrasound somewhere in between there. So the question we asked several years ago was, can we develop a patient-reported outcome to detect recurrence? So we did this study after all that work had been done, and basically we included adults who had at least a hernia repair 1 to 5 years prior to assessment. We also evaluated their quality of life. So this was the ventral hernia recurrence inventory. This is put together after I talked to Professor Uckel and actually talked to some patients as far as what we thought would be the questions that would be most pertinent to developing a patient-reported outcome to measure recurrence. So these 3 questions that you guys are all familiar with. Do you feel your hernias come back? Do you feel or see a bulge? Do you have physical symptoms or pain at the site? So we actually, for this study, we had just over 1,000 eligible patients. We enrolled just over 400. And basically what we did was we brought these patients back to clinic, performed a blinded ultrasound and also a physical exam assessment, and also gave them the patient-reported outcomes, the ventral hernia recurrence inventory beforehand, and we just assessed what the results were. Well, here are the results of that study here, and these are the 3 questions. The black bar is the overall result. The kind of speckled dotted bar is the folks who actually had a positive ultrasound, and the wavy bar are those who had a negative ultrasound. So if you look at this and you just kind of look at this comparison here, you see that the bulge question itself actually had the most discriminating capacity based on this. What we found is that the question about pain overall was too sensitive. We had a lot of people who actually had a fair amount of pain after their incisional hernia repair. And this was also confused with, do you feel your hernias come back? A lot of patients confused pain with the hernia coming back when actually it wasn't a recurrence, they just had pain. And so we did receiver operator characteristic curves. Basically, you want these, the curve to be kind of around the top left is basically what you're looking for. So if you look at the 3 questions, the best accuracy really was the bulge question compared to recurrence or pain. And then we looked at sequences of questions as well. And we found that there really was no difference. The area under curve for the bulge question, just over 0.83, seemed to give the best performance overall. And so that led basically to the calculation of the sensitivity and specificity and the predictive values for these 3 questions. And this is what we found is that the question, do you feel your hernias come back, is the most sensitive, but again, it's almost too sensitive. And the best single question, basically balancing out the true positives from the 2 negatives, was do you feel or see an actual bulge? And this is the algorithm we came up, which was published in the American Journal of Surgery. So if you wanted just a single best PRO to determine long-term hernia recurrence, ask about a bulge, have a patient determine if they feel there's a bulge or not. Again, it's not perfect, but it overall has very high sensitivity and reasonable negative predictive value, higher than physical exam. If you want the best combination of PROs to rule out a recurrence, you ask these 2 questions, and here's the algorithm. If it's no to both, they pretty much don't have a recurrent hernia. If it's yes to either, then physical exam, followed up possibly by a radiographic study. So this is the overall recommendations of how to incorporate PROs should you want to do that in your practice. So the next question we asked was, does this work for inguinals? And we worked with Luciano and his group and a lot of contacts in Brazil. And we actually administered the exact same hernia recurrence inventory to patients undergoing inguinal hernia. Basically the same study design. You had to be at least 1 year out of your inguinal hernia repair. And we compared that to the gold standard of physical exam. And as you can see, we had to translate this, of course, into Portuguese as well to be administered in Brazil. And these are the results here. So we enrolled about 67 patients and also performed, and some of them had bilateral repairs. So there were some more hernia repairs in patients themselves. The analysis was performed at the patient level. And this is what we found. Again, same thing that we found was that, do you feel or see a bulge? Had the best balance between detecting hernias and also ruling out the fact that you had a hernia as well. It had the best performance overall. Then the final thing we did in terms of evaluating the hernia recurrence inventory was look at the real world performance of this. So basically in the QC, and this we most recently just presented, this is the AHS, we looked at all the QC data for patients who had, of course, the hernia recurrence inventory administered and also had either an MRI or a CT scan at least 1 year after their hernia operation. We included adults, just elective repairs, and we included those who had at least 1, 2, or 3 years after their repair. So we just compare the PROs versus the gold standard of an MRI or a CT scan. And we included just under 2,000 patients. You can see the population description there. Interestingly enough, the mean BMI here was 33, which was the same body mass index that we had in our Vanderbilt prospective cohort for the recurrence measurements that we did. This is a much higher than, of course, what Professors Yekel and his team in Lewendijk had in their Dutch study. The hernia, what you see there is fairly large hernias, just over 12 centimeters. So this is what we found. Again, this is all the QC data most recently in kind of the real world assessment of the hernia recurrence inventory. So if you look at this, the sensitivity wasn't as high as we had discovered in our prospective studies. And also the specificity was lower. The negative predictive value was quite high. Again, confirming that if the answer is no, they likely do not have a hernia. And so overall, fair performance, but again, not as good as what we found in our prospective cohorts. So in summary, then the hernia recurrence inventory with the confirmatory testing for a positive result gives the most accurate results after ventral hernia repair. That's the best way to use it. The bulge question alone is probably the best balance of characteristics for a sole PRO assessment after ventral or inguinal hernia. But we do know after this real world evaluation and after multiple other studies that this does tend to overestimate the true recurrence after ventral hernia repair. But if you balance that versus not having any information, which is often the case when you're relying on physical exam or a radiographic study, this is a reasonable balance in terms of assessing recurrence across the board. Great, thanks a lot, and I'm happy to answer any questions.
That was really great, Ben. I don't see any specific questions from the group, but I'll ask you, how have you implemented this into your practice? I mean, I know you guys have a robust team at Ohio State working on care for patients with hernia and hernia-related disease. What have you done specifically to implement this, and how have you seen that maybe improve or affect the ability to follow up long-term with patients who have had hernia repairs with you and your colleagues?
Yeah, this says we've actually switched to pretty much all telehealth for 1 year plus hernia follow-up. And that includes definitely ventrals. We've actually instituted for our inguinals now as well, just because it's relatively easy to do. Our nurse practitioner does it. Prior to the telehealth visit, all patients get the whole PRO battery, including the hernia recurrence inventory. And if that's positive, then that clues whoever is talking to the patient via the telehealth visit to ask them a little bit further about it. And then if the patient and that provider are concerned about it, they come in for a physical exam and a possible confirmatory radiographic study. So we use it as originally intended, more kind of as a screening test than anything else.
Ben, great talk. I mean, it's a great study also. Now, if you have a patient now, if you think you have a suspicion, do you do DASH or do you send it for CT or?
Yeah, I do the DASH just because it's pretty easy to do in my clinic, especially for folks who have a BMI below about 40 or so. Above 40, and with folks with a significant amount of subcutaneous tissue, probably over about 4 centimeters, it becomes difficult to really kind of discern things. But below that, yeah, I usually start with the DASH. If I can't discern things very well, then I'll follow it up with a CT.
Following question, do you get yourself for practical purposes, do you get certified in ultrasonogram for like focus other than like what we do in trauma?
Yeah, it's a similar process. Basically, the requirements are you should take the ACS ultrasound basic course. That kind of provides the basic, that's part of our credentialing process here at Ohio State. And then after that, it's just a lot of practice, just like, the FAST exam for trauma. You just got to do it a lot of times and you get more and more familiar with it. The interesting thing is using a high resolution 12 megahertz linear probe, most abdominal wall surgeons, you'll immediately be able to see all this stuff. And honestly, it answers, it's really great to assess for like epigastric hernias, epigastric recurrences. Where it's really difficult is around the umbilic because you got to angle it in. It's a little bit more challenging. But yeah, I use it pretty frequently.
Nice.
There is one question from Jeremy Warren. He says, very nice, Ben. Is there any plan to operationalize this information to get some notification back to surgeons when a positive screen occurs?
Yeah, that's a great question. We've been thinking about that for a while. And I think it's time we had some feedback around that, because right now, you're right, the system basically stops unless someone's actively looking at that. And that's something we can definitely implement. I think, long, kind of medium term, that might be something we definitely need to look at.
Okay. All right, moving on, I guess it's 8:28. Our next speaker is Dr. Kevin Baier. I hope I pronounce it right. Kevin, it's about what is the clinical significance of a seroma in the long term.
Hey, Kevin, this is just real quick. Sorry to interrupt you there. If anybody has any questions during the talks, just to reiterate, if you use the question and answer feature, then the moderators will go ahead and kind of address those questions for you, and we'll kind of keep things going. Feel free to, while things are going or afterwards, and if it's after one of the speakers, we'll go ahead and jump back on there. Sorry about that, Kevin.
Oh, no problem at all. So hello, my name is Kevin Baier. I'm the current abdominal wall reconstruction fellow at the Cleveland Clinic. And so thanks for inviting me to talk today about the long-term clinical significance of seroma formation and clean ventral hernia repairs. So I have no relevant disclosures. Seromas are surgical site occurrence that we track and routinely report and collect data on, but don't necessarily truly understand the long-term implications of. And surgical site occurrences have been implicated in hernia recurrence, but SSOs as a group is a pretty broad category with a number of different wound morbidity. And so the question we ask is, what is the significance of postoperative seroma specifically after ventral hernia repair? So we set out to answer this question utilizing the pooled data from the ACHQC. And so our inclusion criteria were elective, clean ventral hernia repairs with mesh that also had available 30-day and 1-year follow-up. So we excluded peristomal hernias and repairs of diastasis. And then we used propensity score matching based on preoperative characteristics to create similar baseline groups between those with and without seromas. And then we define our primary outcome as 30-day wound morbidity, namely SSOPIs or surgical site occurrences requiring a procedural intervention and antibiotic use. And our secondary outcomes as PROs at 30 days and 1 year, as well as hernia recurrence at 1 year. So our initial query identified 4,062 patients that met our inclusion criteria, including 221 with seromas and just over 3,800 without. That allowed us to do 3-to-1 propensity score matching, with ultimately 216 patients in our seroma group and 631 in our no seroma group. So what we matched on were just preoperative factors, and you can see those listed in our plot of the standardized difference of the means. And you can see pre-matching in red and post-matching in blue. So after matching, there were a few differences that we noted in operative details. I don't think many of them come as too surprising. Seromas were more common in minimally invasive repairs compared to open repairs. And they were more common in patients undergoing repair of an incisional hernia as opposed to a primary hernia. And then there were some factors that seemed to be protective against seroma formation. Those included transversus abdominis release versus no component separation, as well as primary closure of the hernia defect versus a bridge repair, and drain placement. So when we examined our 30-day wound morbidity, we found that the postoperative seromas were associated with an increased risk of SSOPIs, with 19% of patients in the seroma group requiring some type of procedural intervention versus 4% in the no seroma group. The specific SSOPIs that patients in the seroma group required, the vast majority of those were percutaneous drainage. 13% of those of the total 19. So that was 29 patients. And then wound opening in 12 patients, and then wound debridement in 4. Importantly, there were no partial or complete mesh excisions in the seroma group, and there was 1 partial mesh excision in the no seroma group. And then when we looked at compositive antibiotic use, we found that patients with seromas were more likely to require antibiotics postoperatively, 12% of those patients versus 3% in the no seroma group. So next, we examined the patient-reported outcomes, and this table is a little busy, but essentially demonstrates that at 30 days and 1 year, there was no difference in the median Hercules scores between patients with seromas and their matched controls, and the same was true of the NIH PROMIS pain scores. And then looking at recurrence, we saw that at 1 year, there was no difference in hernia recurrence when measured by PROs, clinical assessment, or by composite measure. So both groups had a reported 17% recurrence by composite measure, and then a 7% recurrence by clinical examination. So from this, I think that we can recognize that patients who develop a postoperative seroma are at increased risk for needing some type of procedural intervention or antibiotic use after their operation. But our data suggests that despite this increase in the 30-day wound morbidity, that there does not appear to be a negative impact on the quality of life or hernia recurrence at 1 year. And certainly longer-term follow-up would be required to determine if these things could lead to earlier or more frequent recurrence. And we certainly have limitations in that our retrospective design and our data requiring physician entered reporting, and the fact that there really isn't a standardized criteria for what patient is reported as a seroma versus what is not. And so if you looked with an ultrasound, I'm sure you'd find many more. In our practice, essentially, if a patient notices it, then that's what we report, and we call that clinically significant. But I think that there's a lot of variability in that. But nevertheless, I think that our study helps us as we consider the implications of a postoperative seroma, and helps us to counsel patients as we discuss the management and anticipated outcomes. Thank you.
All right, Kevin, great study. We don't have any Q&A, no questions open, but I just have one question from my side. Why do you think they start antibiotics on patients who have seromas if they think it's?
Yeah, I think it's hard for us to know just from what the data we can glean from the QC. I think knowing that there is a collection under the skin, I think physicians are more willing or more eager to place a patient on antibiotics with the thought that there's a potential space and fluid that could become infected if they notice any redness or tenderness or concerns about the appearance of the wound. But I can only say that from our experience and not from the data.
Hey, Kevin, can I ask you a question?
Absolutely.
And you can phone a friend to Ben if you want for this as well. So I think, and even Ivy actually has some role in kind of defining these terms of how we measure things. And I think that, my question revolves around the term SSOPI. And I think, our intention of that term was kind of to say it's a clinically significant wound event, that there was some intervention performed. And I think that the kind of implications of that are that there might be some safety issues, both short-term and long-term. But one of the things that this kind of data begs the question is, if all of these 30-day things resolve and don't cause long-term complications, is SSOPI the right thing to be reporting for safety and outcomes around wound events, or is it just too sensitive, not specific enough? And is one, and two is, does, like we often talk about, does SSOPIs matter at all? Like, who cares if you get it?
Yeah, I think while like seroma specifically don't seem to imply long-term issues with hernia recurrence or quality of life, I think short-term wound morbidity and understanding both its incidence and what can contribute to it, as well as those things that require some type of intervention. Patients who require readmission for some of these procedures, like all of those quality measures, I think are important to healthcare systems as we define like quality of care and the cost efficiency of care. And so I think even if that doesn't result in like a clinical recurrence, I think the definition of success in hernia management isn't limited to recurrence. So as we think about like healthcare utilization, then I think that there's still important things to measure.
Hey, you guys got a question in the, hey, Ben, follow directions. Put your questions in the Q&A, not in the chat. But Ben had a question. Ben wanted to know if you treat a sub-Q seroma differently than you would potentially treat a retromuscular fluid collection. And just to be clear, I don't think we looked at that, and I don't think the QC differentiates that, does it?
No.
Yeah. So I mean, but Kevin, why don't you go ahead and address how we manage those two?
Yeah.
The data doesn't answer that.
Yeah, I don't think the data answers that. In general, I would say we treat them similarly, and if there's no evidence of infection or issue, then the vast majority of these we wait. If they don't resolve over the course of the first few months after surgery, that's when we start thinking about drainage, and or if they are symptomatic enough that it's causing the patient grief. But I'd say the vast majority of these we sit on.
Well, maybe I just add one thing to that, just to
Yeah.
clarify. So, because I think it's a good point. I think a sub-Q seroma, to me, is more often just a natural result of a procedure, particularly for a bigger hernia.
Mm-hmm.
I would just say retromuscular fluid collection would be incredibly unusual. And honestly, I think in our practice, that would result in some type of intervention. If I saw that, I'd be concerned that something is wrong. I'd be concerned there's a urine leak. I'd be concerned that there's an infection. It's an incredibly uncommon event. Again, we didn't figure that out in this study, but just for kind of doing a lot of these and managing these folks, this is outside this study, but just as a thing, I think that retromuscular fluid collection, something's wrong. You have to figure out what's wrong. It's not always life-threatening or a disaster, but that should not occur in these operations. I mean, Ben, you asked, do you agree with that, or?
Yeah, I think so. That's kind of what I was getting at, that, these are treated very, very differently. Obviously, you mentioned the study doesn't address that, but it's important to make that distinction clinically. I'd say, after 30 days, you shouldn't have much of that retromuscular space. It should be pretty clean, at least radiographically. Yeah. The other thing I would mention about do SSO PIs matter? It's interesting if you go back about why SSOs were created. SSOs were created because SSIs were a little too restrictive in their definition and just didn't capture a lot of the wound events that a lot of our patients have. SSOs, on the other hand, are actually probably too inclusive of just about anything. And so that's why SSO PI was developed, and it probably is a reasonable balance of things to measure interventions for those SSOs.
I have one question to Mike and Ben and Kevin. Do you think, if you're talking about retromuscular seromas, like we are talking about 30 days, like how do you differentiate whether it's a hematoma or a seroma?
You need to do that. If, and again, this is not based on data, this is just my, management style. If there is fluid in the retromuscular space, something's wrong. It might be hematoma, it might be urine, it might be communication with the peritoneum, it might be an infection, it might be something. But I think when you see fluid in the sub-Q, you can easily say, hey, that's just a result of the hernia sac filling up, with fluid. But in the retromuscular space, even at 30 days, it is extremely uncommon and is the sign of something that's wrong. And so, if it's a hematoma, you should be thinking about washing that out to get your mesh incorporated. They often require something, not just observation, I think, is the difference. You guys had a couple questions on the Q&A too. Rob, you want to take those?
Sure, yeah. So there are two questions somewhat related. So I'll piggyback them and then you guys can answer them both in turn. So seroma recurrence or seroma occurrence as it relates to mesh fixation and hernia sac excision. Any thoughts on that, whether seroma development is related to either one of those, either seroma or mesh fixation or hernia sac excision?
Kevin?
Yeah, I don't think like from our data we can draw any conclusions about that. I think that there's a role for getting rid of some of the hernia sac when it doesn't come at the risk of compromising the skin or soft tissue, and as far as fixation goes, that doesn't affect how we're sort of approaching this, but it'll be interesting to see if there's any sort of difference in seroma formation in our ongoing fixation trial, to see if there's anything or any difference in incidence between our fixation and no fixation in retromuscular repairs.
Hey, could the panel just vote? How many folks routinely resect every single hernia sac? Raise your hand. Come on, Rob. After 4:30 p.m., how many people routinely resect every hernia sac? So I used to do it,
but most.
I used to do it. I almost never do it anymore. I don't know. Kevin probably could verify more than anybody if I'm actually speaking the truth, but I rarely do it now. I think most of the people get seromas and it goes away anyways. There are probably a few times where I do it, but I'd probably say, I bet I do it less than 20% of the time. Is that, maybe I leave and you do it though. Is that accurate, Kevin? What percent do I resect the hernia?
No, I think that sounds about right. I think if it's like particularly large, or we may resect some of it, but if there's a big space there, we may leave this subcutaneous drain in addition to the retrorectus drains that we left.
All right, this has been a good conversation. I think given the time and a couple more presentations, we should probably move on. Our next presenter is Bill Hope. He's going to be talking about port site hernia evaluation. So really looking forward to this talk. Thanks, Bill.
Don't look too forward. I'm going to apologize up front. And I think you'll see as this talk goes on, there were some limitations with this study. I'm very interested in it, but hopefully all these smart people on the call can help us kind of go through this. But we are going to talk about port site hernias. I do have some disclosures with working for some mesh companies and upstart companies. But this is really why I thought about this. Besides fixing port site hernias, this was a patient of mine, did a robot sigmoid colectomy, used an 8mm trocar, I believe, I think it was an 8 on the left side. And patient came back. I thought she had a leak. She was super sick, had an incarcerated hernia at her port site on the left side. Took her back, scanned her, saw this hernia, and took her back, and ended up fixing this fairly acute port site hernia, and she just did terribly. I put a piece of mesh in. She ultimately got the mesh infected. My partner had to take it out, and she'd had like 4 or 5 surgeries after that to fix this. So while they're super rare, I think they can be problems, and a lot of them are fairly easy and simple to fix. But I don't think there's a lot in the literature about A, how to fix port site hernias, and B, how often they occur. And this is some stuff, it's a little bit old, but it's from the EHS guidelines. It really was about laparotomy closure, but they talk a little bit about laparoscopy, and probably some of the things you've heard or been taught clearly. And I think, some of the robotic trocars and some of the other people are trying this, the small trocars, but you use the smallest trocar you need. The general consensus is to close 10mm trocars or greater. And then I don't think a lot of people are doing sills anymore, but I know that was one of the big sort of downsides of single incision surgery is because you had to make that trocar so big, there was bigger hernias. This is out of Mike Liang's group. This is actually something I think about a fair amount, because if you sort of think of hernia, when I was doing a lot more lap ventral hernia repairs, I would always be concerned that this 11 or 12mm trocar I made was sometimes even bigger than the hernia I was repairing. And I was always worried if these were quote unquote hernia formers, would they get these big port site hernias over there? And I tend to close these with a suture passer, and really didn't see this. And Mike Liang kind of corroborates this. And really out of 350 patients that he did lap ventral hernia repairs, he only had 1 port site hernia. So while it's maybe not a huge problem, I think, with more MIS, we're starting to potentially see some port site hernias. And so I really had 2 questions for the QC, and I'll show you while some of this may be limited. The first was really just to see how many port site hernias were out there, see how people were fixing them. I mean, I would imagine people are fixing them open, laparoscopic, robotically, all these different things. I just kind of wanted to get a handle on that. And then really my main question, and my second question was, are we seeing more port site hernias after robotic with this sort of uptick in robotic hernias or robotic surgery versus laparoscopic? There's some potential, you know, these ports are a little more, they can move around a lot more sometimes with the robotics. So those were really two of the questions that I was aiming to achieve. And as you can see here in a little bit, I really had trouble and struggle. And like I said, hopefully I'll get some insight from this group. But one of the big problems with the QC, at least for looking at those two questions, is for our categories for abdominal core surgery, port site is not one of the ones. This is when you're actually, so if you're fixing a port site hernia and you get to this page, you're going to type incisional, I'm sure. So we can't ferret that out to see how many port site hernias are being fixed. Now, I will say, and maybe the data entry people can help me, some of these people evidently filled out a sheet and called it a port site hernia. So we do have some data from that. And so really in the QC, we can only get, if you fill out that the patient had a recurrence and what type of recurrence, there is a site for port site hernia on there. So we got a few people with that, but there is, you know, fairly little detail about what size the port was and how they closed it. So there are a fair amount of limitations. And I think that's why you'll see that after sort of looking at all of these patients and starting with our inclusion, which was really all MIS surgeries that were done from the QC, we only came up with 17 port site hernias. And this is a hodgepodge, actually, and I'll really kind of go through the data fairly quickly because it's a little hard to ferret. It's a hodgepodge of patients that underwent port site hernia repair, and then some patients, I think it was 6, that underwent hernia surgery, another type of hernia surgery we'll show you here in the next one, and then had a port site recurrence. And so, again, a little hard to tell about the results, but basically mesh was used in 10 out of these 17 patients, almost all sublay meshes. But when you look at the previous surgery for some of the patients that had the port site hernia, you can see, I mean, you don't really gain a lot about this, but you can see the robotic, laparoscopic, and open hernia repairs that were done. These had pretty good outcomes. They had no SSIs, just 2 seromas. We just talked about some seromas, probably not a big deal, but that's sort of where we are. And unfortunately, I'm open for suggestions here of if there's any way to kind of, because we've got a lot of data in the QC for sure, but there's clearly some limitations to look specifically at port sites until we get such a high volume and people start putting the port site recurrences in the recurrence section, which I know is one of the, you know, hard parts to put in. But so if you really wanted to answer those two questions, we'd have to separate it or try to figure out some way to separate the incisional hernia tick that we do to see if they're port sites. And so unfortunately, this is one of those times where a good research question unfortunately hasn't been answered or really didn't get a lot of data. But so I'm sorry to spoil a lot of people's view, but I do think it's a good way to look at a research question and see if it's something the QC could answer. So happy for suggestions or any thoughts on port site hernias. Let's see if I can. All right.
So, okay. Bill, I have a question for you. I mean, I'm not sure, like I have seen port site hernias from in Bronx, like for 5mm ports also. Do you think it's a difference between like 5 versus 12 versus?
You know, I don't know. I mean, I think the literature will tell you that you should be closing some of these defects that are greater than 10 and that 5s don't. But I'm like you, I've seen them in 5. I sometimes wonder if we haunch these things closed, maybe they're getting ischemia. I don't know if you remember that picture, but it almost looked like, you know, that was acute, that maybe they're getting ischemia and maybe we shouldn't be closing them because some of the gynecologists will tell you not to close them. So that's kind of why I was interested in this project. And I know we can't answer all those questions with the QC, but I think while there's a pretty standard answer of what to do with port sites, I think probably if we all that's why a registry would be great. I mean, if you and I see one or two every few years, but we have a collective group that's seeing them, that maybe we can garner some information about them. But I don't really know. I mean, I know what I'm taught, and I know what sort of the general consensus is, but just like you, I've seen them with 5mm trocars. I've seen them with everything.
I think you mentioned this, but with a robotic platform too, it's not just the size of the trocar, but the effective size of the hole at the end of the operation, right? Because our arm's hitting the table a little bit, or the person's hip. Can you burp it up there a little bit? And all that's doing is just putting a ton of torque on the abdominal wall, which is just post-holing that trocar site, that 8mm trocar site, bigger than 8mm. The one patient I had who came back with an acute port site occurrent, hernia occurrence, and a bowel obstruction, just like your patient, Bill, was just that, is it got torqued open, and I'm sure it was much bigger than 8mm. And so I always watch the trocars come out now, and if it looks like it's been stretched, I close it. If not, then I leave it. Don't know if that's the right thing or not, but.
Yeah, I think you actually said that word better than I did, that torque on there. And again, I mean, I'd be interested to hear some of the robotic folks talk. I've said this before, and they usually say it's not a big deal, but surely the amount of motion on those trocars may have some insight on that.
Well, I think this is a lot more common than we all think it is. I mean, when you do open hernias on these people and you do retromuscular surgery and whatnot, you often see small hernias, from these people, particularly like post-bariatric people where they have 12mm ports up there. You'll almost always, as you're coming across there, you'll find a small hernia. I mean, how many of those are symptomatic and cause emergency surgery, like your case? That's probably pretty rare, and they just don't know about it. But I agree. I mean, look, this might just be one of the downsides. Like there was a downside of sills. There might be a downside of some of the robotic stuff, particularly in hernia patients. As you use a bigger trocar, you're going to, to make a bigger hole, you're likely to see more hernias. It doesn't mean it's a terrible thing or anything. It'd be nice to know what the incidence is. So I think let us kind of think about that a little bit, because to break down all the information about the prior case, all that stuff, it really does get to be a lot of clicks. But I agree, it's an important question, and quite frankly, it's a question that will only be answered in a registry. It's just,
you're right.
You really do need tens of thousands of patients to figure this out.
Well, if the data dictionary folks or anybody comes up with some good ideas, or anybody wants to collaborate with me on this moving forward, I'm happy to, have an interest in it. So Jonathan Wright may have an idea. So, I think the one thing about port site hernias is when you see it, you know what it is. I mean, they're usually, they say they have a hernia on the lateral abdomen. You say, that's not a hernia. And then you go and see a little scar there and you go, oh yeah, that's probably a port site hernia. So you usually know it when you see it. And it's something that you probably, if you're going through the database, could say. Whereas, if you're looking just at an incisional hernia and how many they've had, and, that gets confusing. But usually I think most people that are operating on port site hernias, unless it's confused with a Spigelian or something, you usually kind of know what it is. So it wouldn't be too challenging to go through that and have an extra tick, but happy for any suggestions.
Okay. All right, moving on, I guess we are close to not to get everyone late on this. Our next topic is our research resident and fellow research grant. Ryan, are you around?
Yep, I'm here.
Yep.
Thank you guys. My name is Ryan Lamm. I'm a fourth year general surgery resident at Thomas Jefferson University. I want to thank you guys for the opportunity to present and the grant support. Our project was titled Our Short and Long-Term Outcomes in Cancer-Related Ventral Incisional Hernia Repair, Worse than in the General Population. And this is an ACHQC database study. I want to thank Molly and Dr. Palazzo for the privilege of working with them. We have no disclosures, no conflicts of interest. So the question for this study really came from the fact that in incisional hernia repairs, there's lots of factors that influence perioperative outcomes and quality of life outcomes. Some of them are modifiable and some of them are not. Here are a select few. Obviously, there's many more. We also know that certain characteristics about the hernia and repair can affect the perioperative outcomes. But one question we don't know is, is history of a cancer-related operation one of those factors that we should consider in when counseling the patients or performing these repairs? So why is this interesting? Cancer patients on average are surviving well after their operative management for cancer. They're presenting more often for incisional hernia repairs, and we know that their quality of life scores are severely reduced when they do have incisional hernias. But there's no set standard that exists whether or not management of these cancer-related operation patients should be handled in a different way or whether their outcomes differ in terms of counseling the patient. So for our study, the primary outcome was to determine whether or not a cancer-related operation is a risk factor for worse perioperative or quality of life outcomes. And then secondarily, to determine if there's a specific operative approach, whether open, laparoscopic, or robotic, that leads to better perioperative or quality of life outcomes in these patients. We wanted to use the ACHQC. As you all know, it's a pretty unique opportunity to get a large number and look into this. And there was the addition of the cancer-related surgery indicator, which sort of piqued my interest when I was looking through the database with Dr. Palazzo. Our study population includes patients from 2018 to 2020. Obviously, the ACHQC has been around for longer than that, but that's when that cancer-related identifier was added into the system, which is why it's in our inclusion criteria. We chose adult patients greater than 18, and we specifically focused on ventral incisional hernia repairs. Exclusion criteria, besides not meeting inclusion, included any concomitant procedures being done, whether any other hernia repair that was not a ventral incisional hernia was being performed, and we only chose elective cases. We chose the standard perioperative outcomes of interest: surgical site infection, surgical site occurrence, excluding infection, recurrence and reoperation, as well as the PROMIS and Hercules quality of life scores. And we also measured recurrence in time to event fashion, and that was surgeon reported or patient reported bulge. For the first aim, we employed regression analysis to evaluate if there was any association between the cancer-related indicator and the primary outcomes we just discussed, while adjusting for select comorbidities. And the secondary aim was answered using a regression analysis with propensity score adjustment. Here's a flow chart for our sort of plan of attack for that first aim, with the exclusion criteria listed, leaving us with a population of just over 8,000. For our unadjusted results in terms of demographics and characteristics, as I mentioned, we had 8,019 patients total. 1,321 of those were deemed to be cancer-related incisional hernia repairs based on that qualifier that was added to the database, and 6,698 were not. As we can see, the patients who were in the cancer-related surgery cohort were on average statistically significantly older, more likely to be male, a lower BMI, a higher ASA status, and have larger hernias both width and length. Although the clinical significance from those small differences is undetermined or likely not very much. For our unadjusted outcomes data, it showed that, on average, the two populations weren't statistically significantly different, except for in the surgical site occurrence, excluding infection, with propensity for the cancer-related surgery to actually have a lower rate, as well as in the 30-day and 1-year Hercules and PROMIS scores. We saw pretty similar median scores, as well as the interquartile ranges were similar. Here's a FARS plot for the adjusted outcomes measures with the addition of recurrence. Again, the only statistically significant finding we found was that if the cancer-related indicator was selected, those cohort of patients showed a lower propensity for surgical site occurrence, excluding infection. There are some trends on the other perioperative outcomes towards a protective effect on the cancer-related cohort, However, majority of them can be shown to be, crossing 1 and not a large difference. In terms of our second aim, looking at the operative approach, we had to apply additional exclusion criteria to balance the propensity match, which is what's listed here. And we were left with a population of 781 patients. They were split between open, laparoscopic, and robotic procedures in terms of approach, and their outcomes were measured, which are listed here. Again, between the three, not much of a difference between any of the reported outcomes or studied outcomes, which are listed here. We then posed the Hercules scores and the PROMIS T scores head to head in terms of operative approach. And they also did not show any statistically significant difference in terms of the 30-day outcomes that were measured. So our conclusions. There's no evidence of predisposition for the cancer-related incisional hernia patients to have worse perioperative or quality of life outcomes based on this data. In fact, cancer-related patients had a statistically significant less score on the SSO, excluding infections, with an odds ratio of 0.74. And other outcomes, as I mentioned earlier, trended towards a history of cancer-related operation providing a potential protective effect. For our operative approach, we had a small sample size, like I mentioned, 781 patients. So no definitive conclusions can be drawn regarding the operative approach in that patient cohort, which were deemed to have a cancer-related procedure. And at the current sample size, there was no evidence of difference in terms of the 30-day quality of life outcomes between the approach that was selected. So some final thoughts and some questions moving forward. It's unclear why we see this potential protective effect with the history of the cancer operation. Could it be that these patients are followed more closely given their history? Are they referred for hernia repair earlier due to that closer following? Maybe more so than a benign disease that doesn't have as routine a follow-up as potentially a cancer patient. For our operative approach findings, perhaps this just reflects the patient and surgeon heterogeneity that we know exists in the general incisional hernia population. And moving forward, I believe, and I think our team believes that continued study into this patient population is needed as the cohort's growing. More patients are presenting, sort of targeting that quality of life after their cancer procedure and after their treatment. So this is a population that in all likelihood will only grow, and any data we can use to justify our opinions and our counseling would be helpful. But how best to go about finding that answer is really something I want to pose to the group. So should these next steps involve querying the database further, since this indicator was only added in 2018? Should it involve other databases? Should it involve database harmonization for more granular detail, which is normally associated with these cancer patients? And I really leave that up to you. Thank you for the opportunity. I look forward to any feedback, questions.
That's really great, Ryan. My question for you is was it just, and it seems like this was the case based on your presentation, but was it just, yes, they had a history of a cancer operation, now they have a hernia, or did you have a little bit more of that granular specific detail, as in how far out are they from their chemotherapy? What's the status of their cancer? Do they have any evidence of disease? Like all the other factors, are they malnourished? All those other factors that we know may affect outcomes from a hernia repair, as you mentioned on your first slide. There was no difference. So I wonder if, hey, maybe the person had, prostate cancer 6 years ago, and now they've got an extraction port site hernia, and they're totally otherwise a healthy guy. Did you think a little bit about that? And maybe we could suss that out with a little bit more specific study in the future.
Yeah, we thought about that a lot. And, given the data that we found now, actually what we were looking at was really just the surgery that they were getting, the incisional hernia repair related to a cancer operation. So that leaves a big, breadth of different procedures, like you mentioned. So to have that granular detail would be great, especially if we're, thinking that these really are two distinct populations. And, I think the question is still there. Do given the malnourished patient who had a history of cancer versus the malnourished patient who had a history of benign disease, do they still represent two distinct populations, or are they, the same answer? You should increase the nutrition and repair it that way. So I think it would be really interesting to me, and I think really useful going forward to try and figure out, maybe more of the granular details that are involved in answering that question.
There's one question, I guess Rob. There's a question about, did you include like chemotherapy in your analysis? I think that's just follow-up question, I think.
Yeah, unfortunately, no, we didn't have that data available, but I think it would be really useful to use, I think.
Well, so Ryan, listen, first of all, congratulations. I think this is exactly what the database is supposed to be used for. And I think that was money well spent, and great job. My one kind of big comment to you is sometimes the most important finding in research is not finding a difference. And I think oftentimes we forget that, because kind of we all have our biases. We all think we know what's up. And then when the data doesn't prove our biases, it's very difficult to reconcile that. I've been doing this for a long time and I still can't reconcile that. So I think, what you found here to me doesn't really surprise me. And I think you could start looking for chemotherapy and type of cancer and all those type of things. But at the end of the day, I think that what you found is the truth. And my argument for why it's the truth is that hernia surgery is essentially an elective practice for the vast majority of cases. Obviously, there can be emergencies and whatnot. But for something like cancer, those people almost for sure would have been optimized before they underwent these elective surgeries. So while we can't prove that, we're not measuring pre-albumin, albumin, and all those things and know from their time, I think your data kind of implies that due to preoperative optimization, when you optimize an assumption, a patient with cancer, they get an equivalent outcome to a patient without cancer. So I think that's kind of my take home. And number two, about the technique, we have a saying in Cleveland that nothing really matters. As long as you just do a good operation, nothing really matters. It doesn't matter whether you do it robotic, lap, open, what type of mesh you use, whatever. At the end of the day, if you do a good operation, most of the time people do well, not all the time. And I think kind of you also showed that, which is actually incredibly important, which is that the story is that the patients with cancer should go to somebody who feels comfortable doing the operation that they're doing, and then do that operation and feel good about it. And so I think the absence of a finding is really the most important aspect of your work. And certainly keep digging and keep looking and keep querying. But I would have argued you should dig deeper and query more if you found a difference, and then you wanted to figure out why that actual difference existed. But it is unlikely that all the things you suggested, harmonizing the data and all those things, are going to get you to any other subgroup that's going to show a difference. But valuable information. So great work.
Thank you.
Hey, Ryan, congrats again. That was a great presentation. Again, I'll be very short with this thought, and I think this is something that we need to really kind of keep on our minds. So this particular topic of hernia operations after cancer surgery, I think one of the things that we assume after we finish up our hernia operations is that the prosthetics that we use are metabolically done. That's finished. That's how they exist as soon as we close everything up. But as we're learning more and more, they're metabolically active devices that continue to have immunologic modulation, inflammatory modulation over time. What would be really interesting, getting back to your comment about merging data sets and looking at big data sets, is are there oncologic differences with honestly different types of meshes that may have different types of inflammatory reactions or immunological modulations over time? That's the kind of stuff that would be enormously useful to know, because no one wants to be placing a prosthetic that's going to increase the risk of a stage 4 colon cancer coming back in 3 years. And again, that's the line of work that I think this stuff that your findings would lead to. And then combining those data sets, SEER Medicare would be a great way to look at that as well.
Yeah, thank you. That's great.
Okay. Let's see. think we have one question. Chemotherapy within 3 months is captured in the QC. Would probably worth looking into that for a subgroup analysis.
You can keep digging till you find a p-value that you like.
Until you get that 0.05.
Hey,
There's always one hanging out somewhere. You
that's
just gotta dig hard enough.
That's a Cleveland Clinic way. That's a Cleveland Clinic methodology, right?
That's it. Make a bigger N, make a smaller P. That's what we do. All right. Is this it? I think we've done all the talks, right?
That's it.
I think so. Yeah, that's it.
Well, hey, listen, I'll wrap this up. I want to thank Prashanth and Rod. Thank you so much. All the speakers, I thought you guys did a phenomenal job. I think this really kind of highlights what the QC is all about, is using this data to ask questions, and we work through it. And this is a continuous process that we don't ever reach the finish line in one answer, but it's continually digging, continually asking, and continuing to try and get better. And really, to me, this is what the Quality Collaborative is all about. So great work to all the presenters. And again, we'll have our ongoing series since our QI Summit was not in person this year. We'll have another one next month. We'll be sending you guys the details. I just want to stress again, everybody feel free to send this out to your residents. A lot of folks use this as a journal club now, as a monthly event, particularly with all the virtual things. I think it's been great. This is always great discussion. Thanks to, again, all the panel, all the moderators, and all the folks who came in. Have a great month, and we'll see you next month. Thanks, everybody.
Bye.
Stay safe.
Bye.
Bye.
Thank you.